good afternoon, everybody, and thank you for joining us today for our webinar on the National Procedures for Clinical Audit of Medical Radiological Procedures. My name is Agnella Craig. I'm the manager of the team here in HIQA with responsibility for assessing compliance with medical exposures regulations. I will talk a little bit more in the introduction about these regulations, but first I just want to introduce my colleague, Danielle Bracken. Danielle will be discussing the National Procedures for Clinical Audit document that we developed and talking about different sections within that document. So thanks, Danielle, for joining us today. So just to give a quick overview of today's presentation, in this presentation, we'll provide some context to the development of the national procedures by talking firstly about the legislative background and HIQA's function. I'm then going to hand over to Danielle, who'll talk about what informed the development of the national procedures document. So she'll go into some detail on the scoping and literature review that we conducted and the extensive stakeholder campaign that we ran. Danielle will then provide an overview of the National Procedures document. And finally, I'll go through how compliance will be assessed by inspectors when we begin to look at this early next year. So I recognize this is a busy slide and I just step down through each stage, I suppose, with the legislative background. So the European Union, the European Union Directive sets out the requirements for each member state in relation to medical exposures to ionising radiation. This directive was transposed into Irish law through two main pieces of legislation, which are SI 256 in 2018 and then SI 30 of 2019. The main scope of SI 256 relates to medical exposures to ionising radiation in the context of patients, along with carers, comforters, and research volunteers, while the main scope of SI 30 then relates to the public and to occupational or to workers. So HIQA is the competent authority for SI 256, and the EPA, or the Environmental Protection Agency, I'm sure everyone on the call is very familiar with their work as well. They're the competent authority for SI 30. So within HIQA, under this legislation, SI 256, we have both regulatory and competent authority functions. So what is our regulatory function, or what types of services do we regulate? You can see from the graph here that the dental sector has the highest volume of services on our directory, with over 1,000 in our directory at the moment. But these represent, you'll see on the right, the little arrow showing the radiological risk. The dental service typically represents the lowest radiological risk. And this contrasts with, at the very top here, you see radiotherapy centres with only a small number of services available nationally, but this represents the highest radiological risk due to the very large doses of radiation that are needed to treat patients with cancer. I suppose in between these two then, the dental at here and then the radiotherapy at the top, you see we also have a remit to inspect and to assess compliance in general radiography. So that's your general X-ray departments, in departments or imaging centres that have computed tomography or CT scanners, interventional radiology, interventional cardiology, and nuclear medicine. And as we go up through that, the level of radiological risk increases. So this is another graph, I suppose, just to show the level of radiological risk versus the complexity of the service. And this is something that we as inspectors need to take into account when we're monitoring the services that are in our directory. We're going to be coming back to this slide as we go through the presentation and talk about how this relates to the clinical audit strategy and the national procedures document. So in addition to regulating and assessing compliance in these services, HIQA also has a number of other responsibilities, or what we call competent authority functions. These include work we've already completed, such as developing dose constraints for carers and comforters and determining the criteria for acceptability of equipment. We've also established and we review national diagnostic reference levels across a range of different modality types. And we're currently working with the EPA in establishing the population dose report. Specifically, we will give the information for the dose contribution from medical exposures. We also receive and risk rate all accidental or unintended exposures that meet a certain threshold. And on a yearly basis, we share a report on the lessons learned from significant and accidental or unintended exposures. In this way, we hope that other services can learn and reduce or mitigate the likelihood of accidental and unintended exposures. So more recently, the development of the national procedures, which is the focus of today's webinar, became a new function for us. And this came about an amendment to the regulations. In SI 256 of 2018, the initial statutory instrument, under Regulation 13.4, responsibility for establishing national procedures lay with the Minister. However, in 2022, through an amendment, SI 528 of 2022, responsibility for national procedures was transferred from the Minister to HIQA. And so our project began. I'm now going to hand over to my colleague Danielle Bracken, who's going to talk us through how we set about developing these national procedures and then step you into different sections of the actual national procedures document. So I'm just going to stop sharing here, Danielle, and give you a second to bring up your share screen and hand over to you there.
Okay, thanks, Agnella. Just bear with me now. Am I sharing screen?
Yep, that's great. Thank you.
Okay. Okay, so the definition is a good place to start. So when we talk about clinical audit, what exactly do we mean? So from the overarching European directive known as the BSS, clinical audit means a systematic examination or review of medical radiological procedures, which seeks to improve the quality and outcome of patient care through structured review, whereby medical radiological practices, procedures, and results are examined against agreed standards for good medical radiological procedures, with modification of practices where appropriate, and the application of new standards if necessary. In order to prepare us in HIQA for taking on the function of developing the national procedures, we had to establish a project team. So this slide provides an overview of the steps involved. So to start with, a review of literature was carried out and a scoping consultation was used to inform and develop the draft national procedures document. The draft document underwent a focused and a public consultation prior to publication on the 23rd of November. Regulatory guidance also had to be updated, and after a settling in period, we will start to assess compliance, and Agnella will go through this in more detail later on. Okay, so two documents in particular were key in helping to inform the national procedures. So as you can see, the concept of clinical audit for medical radiological practices, which includes diagnostic radiology, nuclear medicine, and radiotherapy, it's not new. Okay, so this EU Commission guidance number 159 was published in relation to this in 2009. So this year in 2023, an updated piece of work, the EU Commission Guidance number 198, was published in relation to the current status and recommendations for improving uptake and implementation of clinical audit of medical radiological procedures. So to inform this piece of work, surveys and interviews were carried out across Europe, and a detailed literature review with specific sections radiology, radiotherapy, and nuclear medicine was included. And this document is a great place to go for additional resources in relation to clinical audit, and it's referenced in the national procedures. So in relation to recent guidance on clinical audit, there are also a number of key documents available that are relevant for each setting where medical ionizing radiation is used, and almost all have been produced or updated between 2019 and 2022, and they all contain practical advice in the form of clinical audit templates and checklists or quality indicators. So there are documents specific to dentistry, radiology, including online resources such as Audit Live, nuclear medicine, radiotherapy, and nursing and midwifery. So more generally then, in relation to clinical audit, there are a number of documents also available, such as Clinical Audit, a Practical Guide 2023, and that comes from the HSC's National Centre for Clinical Audit. and best practice in clinical audit and a clinical audit manual from the Healthcare Improvement Partnership. Again, these are referenced in the National Procedures document. Okay, so that's the documentation. We also carried out a number of stakeholder engagement activities, which took place over 3 separate phases. So phase 1, the scoping consultation, involved meeting with key stakeholders from professional bodies and regulators of those professions. And then we asked those stakeholders and some additional interested parties to provide feedback to us through a focused consultation in relation to the draft national procedures. And then we launched the draft document on our website in June for public consultation for a 6-week period. And a full list of the stakeholders involved is included in Appendix 1 of the document. So in relation to that initial scoping consultation with regulatory bodies and professional bodies, we asked them about their interpretation of clinical audit relating specifically to medical radiological procedures, the types of clinical audit currently carried out in their settings, and how clinical audit affects the professions and members. So this word cloud depicts some of the feedback received at those meetings, but generally the main points expressed were that the national procedures document should be clear and concise. The approach to audit should be multidisciplinary. The benefits of clinical audit should be included, and governance for clinical audit should be clear. Also, clinical audit should be embedded in everyday practice where possible, and clinical audit is everyone's responsibility. So the literature review and feedback from that stakeholder engagement helped to inform the principles for clinical audit that are included in the document. So there are 9 principles in total, and they relate to assurance, oversight, communication, resources, teamwork, focus, coverage, tools, and action. And we'll revisit these principles again in more detail later on in the presentation. So the next phase of the stakeholder engagement was to send a draft copy of the national procedures to stakeholders as part of a focused consultation. So these are the questions we asked stakeholders to consider. So are the principles and essential criteria for clinical audit clear? Are the sample templates useful? Are appendices clear? Are there any additional resources that would be useful to add? And is it clear what undertakings need to have in place to be in compliance? So the general consensus then from the focused consultation was that the document, its templates and appendices were easy to understand and useful for undertakings and staff working in the area of ionising radiation. So that feedback was incorporated and the revised draft document was then made available for public consultation for a 6-week period. That was from the 19th of June to the 31st of July 2023. And social media campaign, you can see the flyer there, was used to alert relevant stakeholders. So in relation to the draft document, we asked, is it clear in this document what undertakings, so providers, need to have in place to be compliant with the requirements for clinical audit in the regulations? And is the framework, so the principles and essential criteria, understandable and clear? The general consensus then from the public consultation was that the document was easy to follow and it was clear what undertakings needed to have in place to be compliant with the regulations. And the templates and appendices were also identified as useful for staff in the relevant services. The national procedures document then, along with a statement of outcomes from that stakeholder engagement and an infographic, which you can see here, providing a high-level overview of the document, were published on HIQA's website on the 23rd of November. And at the end of the presentation, Agnella will show you where exactly on the website to find these documents. Okay, so I'm going to move on now to a brief overview of some of the key elements of the national procedures document. So the benefits of clinical audit as outlined in the document are to improve care, improve services, promote learning, and better use of resources. So we're back to this slide again. I'm going to just to discuss the principles of clinical audit in more detail now, and Agnella will provide information on how compliance will be assessed later on in the presentation. And just to mention, Appendix 2 of the document provides more in-depth detail in relation to the principles of clinical audit and their application. So what do we mean then by assurance? So an undertaking must be assured that the national procedures have been implemented and maintained in line with the level of radiological risk within their service. And when we talk about oversight, we mean that an undertaking must have some mechanism in place which identifies the oversight of clinical audit in the service. They must have an identified clinical audit strategy, and that should be aligned with the level of radiological risk in the service. The strategy must also be up to date with evidence and maybe national priorities that will be relevant to that particular care setting and implemented throughout the service. In relation to communication, an undertaking must ensure appropriate communication pathways are in place for all interested parties and stakeholders, which includes staff. In terms of resources, an undertaking must be aware of and provide the resources that are required to implement their own particular clinical audit strategy. When it comes to teamwork, an undertaking must ensure that where possible, the approach to clinical audit includes a multidisciplinary team. Now, for a small dental service, this may include the other personnel working within the service, such as the medical physics expert or the dental nurse or administrative staff, for example. Focus. So an undertaking must ensure that clinical audit is prioritized based on risk and service needs in order to improve practice and the quality and outcome of patient care and their services. In terms of coverage, an undertaking must ensure that the scope and depth of the clinical audit strategy is appropriate for their care setting and clear. Tools. An undertaking must have identified and made available the appropriate resources and tools to facilitate clinical audit. And then action. An undertaking must have a mechanism in place to ensure results and recommendations from clinical audit are addressed, re-evaluated, and that quality improvement plans are implemented and sustained. So what does that mean then for patients and people using the service? So it means they can expect a service that is focused on continually improving its safety and quality, and ensures that the most appropriate procedures and treatments involving medical exposures are delivered safely to each person using the service. For staff, they can expect that the service in which they work helps them to understand the role of local clinical audit, encourages them to actively participate in clinical audit and foster a culture of regular quality assurance and continual improvement, and encourages them to implement recommendations from clinical audit findings to improve quality and safety in the services that they provide. For undertakings, they should have a clinical audit strategy in place. They can use clinical audit to improve the quality and safety of patient care and services. They can use the findings of clinical audit to provide assurances of the quality and safety of patient care and services that they provide. And they can make this national procedures document available to all staff involved in medical radiological procedures so that they are aware of their role in relation to clinical audit. So this slide outlines the relationship between the clinical audit strategy, the audit schedule, and the audit topics. So the strategy should outline how often and when audits take place, so that is the schedule. And the schedule should contain the list of topics due to be audited. So audits then can be categorized into 3 different types: structure, process, and outcome. So structure would be, for example, facilities and equipment. Process could be, for example, the justification process, and outcome could be, for example, the results of examinations or treatments. Appendices 6 to 9 provide examples of audit topics in this format of structure, process, and outcomes for individual care settings. So then having a clinical audit strategy in place is the first step in meeting compliance, and it needs to document the undertaking's approach to the 9 principles of clinical audit. So in its simplest form, what does that strategy mean? So in relation to the principles of assurance, oversight, and resources, it's important to document who is responsible for providing that assurance, who has overall oversight, and who is making the decisions in relation to resources. In relation to the principles of communication and teamwork, these relate to who will actually be carrying out the audit. In relation to the principles of focus and coverage, these describe what clinical audit should be done and when it should be done. And then finally, in relation to tools and action, these describe how it will be done, so what methodology is used, and including how findings and recommendations from audit will be actioned. So this slide is up again because at this point, I'll just mention that the extent of that clinical audit strategy will depend on the complexity of the service and the level of radiological risk. So for a dental practice, the clinical audit strategy may be a straightforward one-page document. And we've provided a sample clinical audit strategy with more detail, and that's available in Appendix 3 if services wish to use it. However, none of the templates within the document are mandatory and services can use their own templates. Okay, so we're going to move on now to the clinical audit cycle. There are numerous clinical audit cycles available in the literature, and the document does reference some of these. The clinical cycle that we've used consists of 5 stages. So stage 1 relates to the planning for clinical audit. Stage 2 is about standard and criteria selection. Stage 3 is about measuring performance. Stage 4 is about improving practice. And stage 5 is about sustaining those improvements. So in Appendix 4 of the document, you'll find a clinical audit checklist template illustrated here, which can help to ensure that each steps of the clinical audit cycle is complete. Now, undertakings can, of course, use their own template or method to assure themselves that they have covered the steps within the clinical audit cycle. So, for example, a large Model 4 hospital may wish to have a much more comprehensive process in place. So clinical audit then, as aligned with the clinical audit cycle, can be documented through the audit report form. Again, here's an example of a template. It's provided in Appendix 5. However, undertakings may wish to use their own templates. In radiology, the Esperanto Guide to Clinical Audit from the European Society of Radiologists provides a whole suite of audit templates and some templates for audit reports. So we'll just go through the form now. So the top section of the audit report provides some detail in relation to stage 1. So that relates to the planning for clinical audit, such as selecting the audit topic, what stakeholders are going to be involved, and the aims and objectives of the audit. This section of the report relates to stage 2 of the audit cycle. So that is the identification of the standards to be used and the target to be achieved. These sections of the audit report relate to stage 3 of the audit cycle. So that's all about measuring performance. So that consists of how performance will be measured. So that is the methodology used, and documenting the level of performance achieved through the results and findings, and then making a call on whether the performance requires improvement as documented in the conclusion. The recommendation section of the audit form then relates to part 4 of the clinical audit cycle. So that's making recommendations to improve practice. So this may involve a quality improvement plan containing a number of quality initiatives. How a service really approach this quality improvement piece is up to them really to deliberate on and decide. The final section of the audit report relates to stage 5 of the clinical audit cycle. So that's sustaining improvements. So the timing for re-audit will depend on what improvement is required. And if improvements are being sustained, then the frequency of re-audits can reduce to a level that's sufficient to provide assurance to the undertaking. Okay, so in relation to the national procedures document, what I've talked through there were the benefits of clinical audit, the principles and essential criteria, and the clinical audit cycle. And then I showed some examples of sample templates, which can be used but don't have to be used, and they related to the clinical audit strategy, audit checklist, and audit report. So just also to bring to your attention, appendices 6 to 9 include audit topics and links to additional resources for individual settings. And there are separate appendices there for the dental setting, radiology, which includes diagnostic and interventional, nuclear medicine, which includes diagnostic and therapy, and radiotherapy. So thanks for your attention. And Agnella is going to talk now about assessing compliance.
Thanks very much, Danielle. I might just ask you to let me know if you are seeing my screen. Am I sharing
Yes,
okay?
we
And can
can.
you
Yeah,
hear me?
we can see
Great.
it. Yeah.
Okay. Thanks very much, Danielle, for that. A very quick overview of the process that was used. It was a lot more, it took a lot longer to develop the process than present on it. So thanks very much for a very comprehensive overview of the process. And then also for identifying what undertakings need to have in place to be compliant with the national procedures. I'm now going to move on to what we in HIQA will be looking at when we're out on inspection. And I will also talk about the specific documents that we have updated, which give some more details on this. So I just want to check, is everything okay? You can see and hear me okay still.
Yeah, I can see and hear you, Agnella.
Great, lovely.
Yeah,
Thanks, Danielle.
yeah.
Okay, so just moving on. So I suppose more generally, before we look at clinical audit, just for those that may not be aware, how do inspectors assess compliance? I'm going to talk more generally first, and then I'll go specifically into what inspectors will look at for clinical audit. So more generally, and those on the call that have been involved in an inspection so far will know that inspectors gather evidence when they're out on inspection. So how they gathered this is by observing the practices that they see in place. So they go into different sections in the service, different rooms. They also speak with staff, and they read the policies, the procedures, the guidance documents that undertakings have developed and have made available to staff. And from this, we talk about triangulating our evidence, so bringing it all together and coming up with a judgment. So, having looked at the evidence we've gathered, the three judgments that are available to us then to make a decision on are compliant, and this means the requirements of the regulations have been met. The next judgment could be substantially compliant, and this means that some action is required, but the gaps that were identified usually carry a low risk. Then we have not compliant, and this is where considerable action is required to come into compliance. And undertakings may be risk rated orange or red in relation to the non-compliance, depending on the timeline and the timeliness of addressing the gaps that have been identified. We've provided more details about this across all the regulations in our guidance to the assessment of compliance and in the assessment judgment framework, which I'm just going to show you here now. So this first document is the guidance on the assessment of compliance in undertakings providing medical exposures to ionising radiation. And this document applies to both medical services and dental services. It can appear quite lengthy, but hopefully it is easy to read and useful for undertakings. We've updated this recently to include the clinical audit piece. And we use that document along with the assessment judgment framework for undertakings providing medical exposures to ionising radiation document as well. So these documents support inspectors and undertakings and those working in the services by setting out the specific lines of inquiry or the questions that can be used to assess compliance with the regulations that we're looking at or assessing. Inspectors, though, will also use their experience and their professional judgment. They'll need to consider the context that they're inspecting in, the level of radiological risk that is posed by that service, and they'll bring all of the information from these documents and from their professional experience and judgments into account when making those judgments. Specifically, then moving on to how we will assess compliance with Regulation 13, Sub-Regulation 4, which states that an undertaking shall ensure that clinical audits are carried out in accordance with national procedures established by the authority. So inspectors will look at the assessment judgment framework which outlines the specific questions or lines of inquiry. So in this case, for Regulation 13, Sub-Regulation 4, it asks, has the undertaking ensured that clinical audits are carried out in line with national procedures established by HIQA? To gather the relevant evidence to answer these questions, inspectors will look at the documentation. So, for example, they will review the local policies, procedures, and guidelines for carrying out clinical audit. Are these in line with the national procedures? They'll look at the results and the reports of clinical audit which are relevant to medical exposures. Inspectors will also communicate with the undertaking and staff working in the facility to establish what systems have been set up to complete clinical audit and what's in place regarding the procedures used to carry out clinical audit. Inspectors will also observe if clinical audit results and learnings are made available to staff, and is there documented evidence, I suppose, as such, of the clinical audit strategy that has been implemented. So these are screenshots that I've taken from our document, Guidance on the Acceptance of Compliance. So that is there, and it's really useful because it steps through the different pieces of information for any of the regulations. I've just called out specifically what is required for Regulation 13.4. So then moving on, to find an undertaking compliant, inspectors will need to firstly see, is there a clinical audit strategy in place? Has the undertaking considered the level of radiological risk in the service? And is this aligned then with the clinical audit strategy that they have developed? Has the undertaking considered the 9 principles that Danielle has talked through already? But if I could go through those again. So for example, inspectors will look to see, has the undertaking provided assurance that the national procedures have been implemented and maintained and that these are in line with the level of radiological risk within the service? The next one then, oversight. What mechanisms has the undertaking in place to provide oversight of clinical audit in the service? So is the strategy in place? Is it aligned with up-to-date evidence? Is it prioritised appropriately? Is it implemented throughout the service? Next then, with communication. Has an undertaking ensured that appropriate communication pathways are in place for all interested parties and stakeholders? So, for example, in a small dental practice, this may be a team meeting with staff working in the service. In a large hospital, which has a large number of staff, what communication pathways have been developed to ensure all staff are aware of what's happening in relation to clinical audit through the different steps of that cycle? So, and are they aware of the findings, the outcome, the recommendations, and the quality improvement piece that may be implemented from that? So we've seen examples on inspection of undertakings, having dashboards set up on staff members' computer screens, which refers to clinical audit and kind of gives updates on clinical audit. We've seen examples on notice boards displayed in staff rooms, emails used or team meetings being used to share information around clinical audit. So then looking at the resources, has an undertaking considered the resources that are required to implement the clinical audit strategy? Have they provided these resources? And then is there appropriate education and training for those that are involved in clinical audit to adequately, I suppose, be involved? Looking at teamwork, has the undertaking ensured that the approach to clinical audit includes a multidisciplinary team? And again, just bearing in mind the level of radiological risk and the number of people working in the service. Danielle has already mentioned in a small dental practice, this may include the other personnel working within the practice, such as the dental nurse, the administrative staff, and perhaps including the medical physics expert as well in designing or feeding into that clinical audit strategy. Has the undertaking ensured that clinical audit is focused and prioritised based on the level of risk in the services, based on the services needs? And I suppose ultimately, have they considered, what the overall aim is, which is to improve practice and the quality and outcome of patient care? Has the undertaking considered coverage and ensured that the scope and depth of clinical audit strategy is appropriate? Is it transparent? And again, does it reflect the complexity of the service type and the level of radiological risk within the service? Looking at the tools then, how has the undertaking identified or made available the appropriate tools to facilitate clinical audit? And again, we're not mandating what these tools should be. These can be as simple as a one-page sheet in a small sole trader practice, or it could be a bigger electronic system which can be used perhaps within a larger entity or a big hospital, ensuring that the appropriate members of the multidisciplinary team are involved to facilitate data collection, I suppose, and possibly automating or looking to see if any of the processes can be automated to collect that data so it doesn't become too burdensome. Lastly, then, looking at the action, what mechanism has the undertaking put in place to ensure the results and the recommendations from clinical audit are addressed? That that the quality improvement plans are implemented and that these are sustained? And is there a period of reevaluation factored in and a timeline identified for this? So in summary, under the European Union Basic Safety Standards and the associated amendments, HIQA has a range of regulatory and competent authority functions. This remit expanded in October 2022 when responsibility for establishing the national procedures in clinical audit was transferred from the Minister to HIQA. Through extensive stakeholder engagement and a 6-week public consultation process, HIQA developed the national procedures document. We've also updated our supporting guidance documentation and outlined how we will assess compliance um, in undertakings, assess compliance with Regulation 13, Sub-Regulation 4, and we will begin to do this in early 2024. So just moving on then, this is the document that we've been talking about today, the National Procedures for Clinical Audit of Radiological Procedures. This is available on our website since November, so just last month. The other documents that I spoke about already are the guidance on the assessment of compliance. That's, as I said, very useful, not only for clinical audit, but for all of the regulations that we look at. And the assessment judgment framework is described as the questions. What are the questions that we ask to look for our lines of inquiry, to look to see if an undertaking is compliant? I haven't yet mentioned these two documents, but these are also useful. The Guide to the Inspection of Medical Services Providing Medical Exposure to Ionising Radiation, and a similar document for dental services providing medical exposure to ionising radiation. So these two documents kind of step through the process that is followed around inspection, and it can be very useful for undertakings and staff working in the services to get a sense, if you haven't already been inspected, as to what an inspection might look like, what are the different stages in that inspection, and what do you need to consider. So these documents are available on the HIQA website. It can be a bit of a minefield to try to find the relevant sections within the website. So we've just highlighted here with the red box, the ionizing radiation section when you go into hiqa.ie. By clicking on that icon there for ionizing radiation, it will bring you into this web page. You can see here ionizing radiation is one of the tabs on the left-hand side, and specifically the information and the guidance that I've talked about today is under this tab, Regulation of Medical Exposures. So at that, I'd like to thank you. It brings to an end the presentation.